Very pleased to have Seth Lerner with us today. He's professor of urology and the director of urologic oncology and department of urology at Baylor College of Medicine. I think well known to probably most all of you. Seth, thanks so much for joining us today.
Thanks, Brent, for having me. Appreciate it.
You've got an abstract that was supposed to be at the AUA, and it's on the OLYMPUS trial. Very important trial that we wanted to talk about a little bit today. Maybe you could provide an overview of the patient population and the treatments associated with UGN-101.
Yeah, thanks. So the target population are patients with biopsy-proven low-grade disease and no evidence of high-grade disease, manifest mostly by certainly biopsy and a normal cytology, and visible papillary disease that's measurable between 5 and 15 millimeters. So as you know, as everyone knows, these patients can be very difficult to manage and often require nephroureterectomy for control of the disease, even though they have low-grade non-invasive and a very low risk of metastasis. So the trouble has been that even though we can access the renal pelvis either percutaneously or via a ureteral catheter, very different from the, you can put drugs up there like chemotherapy, mitomycin we've used, BCG, but it's not retained, right, because of gravity and peristalsis. So you lose all the advantages of contact time, which is important for both immunotherapy and chemotherapy. So the drug is a combination of a thermoreversible gel. So this is basic chemistry where the gel at cold temperatures is a viscous liquid that can be injected through a catheter, a 7 French catheter, or even a 5 French ureteral catheter, or certainly a nephrostomy tube, and it's admixed with mitomycin. So mitomycin is a drug we're all very comfortable with using in the bladder, and some of the properties of mitomycin that we know about are that it's taken up along a concentration gradient. So the more drug at a higher concentration, its uptake is better, and exposure time. And so the admixture of this reverse thermal gel that at body temperature becomes a semi-solid that essentially will stick around in the kidney for 4 to 6 hours. So in effect, you have the contact of mitomycin over this prolonged period of time, which we've never been able to achieve before. And then what happens is the gel is water soluble. So as the kidney produces urine, it slowly dissolves. And so after about 4 to 6 hours, the gel essentially is gone, the mitomycin is gone, but now you've had this very prolonged contact time. Urologists are maybe familiar with this principle. There was a product called Backstop that is the same thermoreversible gel that you would inject above or proximal to a stone in the ureter to prevent migration. I don't know what's happened with that product. I never used it, but the properties are identical.
So maybe we could talk a little bit about the efficacy data that led to FDA approval for this drug. And one more thing, maybe you could be a little more specific on the concentration of mitomycin when compared to what we might be putting in the bladder.
Yeah, so in the bladder, the optimized regimen would be 40 milligrams diluted in 20 cc's. And if you administer bicarbonate by mouth the night before and the morning of, mitomycin is preferentially taken up by the bladder wall in an alkaline environment. And then the last thing we do in the bladder is make the patient NPO after midnight to minimize urine production, scan the bladder right before the installation to make sure there's no residual urine. And so you minimize urine production during the installation and the retention of the drug again to maximize the concentration. So those are the things that we know work in the bladder. And so in the upper urinary tract, the concentration is 4 milligrams per cc of gel. And what you do is you take when you put your ureteral catheter up, you put in contrast and measure the volume of renal pelvis. So this is just for renal pelvis infundibulocalyceal tumors, up to a volume of 15 cc. So at 4 milligrams per cc, patients could get up to 60 milligrams. And then we just do that once a week. The vast majority of the patients had this done through a ureteral catheter that was placed on a weekly basis, although you can do it with a nephrostomy tube, and the FDA approval includes administration through a nephrostomy tube.
Great. Maybe you could talk a little bit about the tolerability and side effects, because you know in the bladder, we do have some irritation, even a granulomatous effect that can occur with sort of calcifications that occur. I've seen that a couple of times, but I don't know if you've seen it in the upper tract.
I didn't answer the other part of your question about the efficacy.
Oh, please.
When we met with the FDA in designing the trial, they actually set a very low bar for efficacy. So the idea here, of course, is we're leaving a tumor behind, and roughly about half of the patients had what the urologist designated as unresectable disease. So either from just a sheer volume standpoint, or in the lower pole, where all urologists know that though you might be able to get a scope into that and see it, maybe you can do a biopsy, but treating with a laser, for instance, is often very difficult because of access. So about half the patients met that criteria. The FDA, because it was such a huge unmet need, and the idea was to try to help people prevent the need of having to go on to a nephrectomy or nephroureterectomy, they set the bar for efficacy. Now, efficacy was ablation, chemoablation of the index tumor measured at the first ureteroscopic evaluation. So they were treated weekly for 6 weeks, and then 6 weeks later got evaluated by ureteroscopy. So we were looking for complete disappearance of the tumor. If there was anything visible, you had to do a biopsy, and that biopsy had to confirm no evidence of disease. So the FDA set a bar of about 15%, which obviously for all of us, it's a low number, but they did that because we didn't really know what to expect.
Sure.
And because it's an unmet need. So surprisingly, 59% of patients, so 71 met all the eligibility criteria and got at least one treatment. 59% of those patients at the first disease evaluation had a complete response. And that was similar in the resectable versus unresectable group. So that was very encouraging. We are continuing to measure durability at 12 months. So all the patients that had a complete response, and that was 41 of 42, went into the maintenance. So maintenance was administered monthly, up to 11 treatments out to a year. And the Kaplan-Meier estimate at 12 months, which suggests that the majority of patients have had a durable CR, but we really need to get all the patients out to that 12-month mark before we can report a real accurate number. So that's the efficacy data. Now, you asked a really important question about toxicity and side effects, and what you describe in the bladder, I think we've all seen. And one of the properties of mitomycin is it's a desiccant. So as a result, if it gets into, say, the surrounding serosa or outside, the mucosa or the lamina propria, it can cause necrosis. So that's what happens in the bladder. You get all this dystrophic calcification, can be a real challenge to manage. But what we saw in the upper tract study was what we called ureteric stenosis. So most of those were grade 1 and grade 2 events, and a minority were grade 3. But this appeared to occur at a frequency that I think was probably higher than most of us expected. Certainly some of it is due to repeated instrumentation, but I think we have to acknowledge that some of it's likely due to the effects of mitomycin. Now, most of these patients could be managed with stenting. Some had to be balloon dilated, but there were some patients who went on to get nephrectomy who, simply because of the challenge of managing, what amounted to severe stricture disease. And even a couple of those patients, I forget the exact number, had no evidence of disease in their kidney. So this is something that we'll have to monitor quite carefully. A small group of us are putting together a protocol for use of steroids in these patients. Short courses of steroids, at least in anecdotal cases, seem to be of benefit.
So talk to me a little bit about where this fits in the current treatment paradigm. What would you tell the practicing urologist right now?
Yep. So, it's really important to keep in mind that this is only for biopsy-proven low-grade disease. So that's first and foremost. It's only for patients who have disease up in the renal pelvis or infundibulocalyceal system. Now, if you happen to have, and often occurs, both ureter and renal pelvis disease, if you can ablate the ureter by standard techniques, laser or otherwise, then you can use this to treat the disease proximal to the ureteropelvic junction. But I think a way to manage this is to make a good faith effort to ablate where you can. If you can get the patient completely ablated, that's probably the best thing for them. If you can't, or if you come back, say, 3 months later or 4 months later, whenever you do your follow-up ureteroscopy, and you've got disease again, take a measurement of the volume, assess the volume, and I think that's a perfect place to use this drug. And then I've already had one fellow out in the community, urologist who's a good referring doctor. He's got a patient right now that he thinks is going to be a good candidate. Those of us that have experience with this, we consider ourselves a resource. The company is going to help connect urologists out in the community who don't have experience, because there is a bit of a learning curve to administering this and to do it right and safely. But we'll see what the uptake is. But for the first time, we've got a new approach of chemoablation, treating tumors that are in place, often difficult to get to or large volume. And, I think it really does potentially fill a big unmet need.
What do you think the endpoint's going to be here, Seth? When might we expect some results from the trials?
Well, in addition to the abstract presentation, we've got a paper that's been published. So sorry that I didn't mention that before. The reference is Lancet Oncology. The publication date, I think, was April. It's been out for a couple of weeks. Nir Kleinman is an Israeli urologist who I think Nir put about 10 patients on the trial. He's the first author. I'm the senior author. So if you search on either one of us, you'll be able to find it. All the data is there. And then we'll come back, when we have the full durability data, we'll report that separately. That's probably another 6 months.
Great. Good to hear. Looking forward to that. Anything else as a take-home message for the listeners?
Yeah. So, I get asked a lot, what's next? What I'd like to see is a study where we can use this as an adjuvant. So in patients who, much like we do, and so most of what we do in the bladder is adjuvant therapy, right? We teach that you're supposed to remove all the visible tumor, and then essentially you're treating residual disease that's subclinical. So I think that the same situation exists up in the kidney. Also, is there an opportunity for other drugs that can be admixed in this gel? The company is doing this, taking the same approach in low-grade disease in the bladder. They've reported some phase 2 data from Europe. They've conducted a small phase 2 trial here in the US, and I believe they're planning for a phase 3 trial taking the same approach in bladder. So, I suppose stay tuned.
Great. Well, Seth, this has been fascinating. I sure appreciate you spending time with us today.
Well, thank you for the opportunity, and hopefully we can do it again.